we're going to do something a little different today. And we're going to give it a shot, and it's going to involve all of you. It is an interactive case study. So I want to make sure this is the one time when we do an interactive case study that I want you to have your cell phone handy. And you're going to be using your cell phone to be able to participate in some of the questions of the interactive case study that we're doing today. And I'll give you more instructions as we get to it. But we came across this idea of, I always like to do this live, where I bring a case or somebody volunteers to be a case, and we are able to basically work together as a group to be able to identify what the limitations are, what some of our primary objectives are, and then how we're going to make modifications, and then design the program. So this is a very typical process that we do in Polestar of problem solving and designing treatment plans. And if you think about it, the three primary elements of being a Pilates teacher, according to the PMA, is first being able to assess and design a program for a client. Number two is being able to teach the Pilates methodology and philosophy to the client. And then third is reassess and modify. So if you think of two of the three skills that we need to have in our profession have to do with assessment and design and modification. So that's really what we're going to be doing today. And I want to jump right in. So let's go to the first slide. So in the first slide here, we're going to do a case on osteoarthritis today. And Jane is a 61-year-old female. You might want to even take a few notes on the side if you have a little pad of paper, and just be thinking of key things that jump out at you as we're sort of going through this case, right? So 61-year-old female, she's a senior partner in a law firm in Miami, very well educated, very healthy looking. She enjoys hiking, biking, yoga, and limited gym workouts. She and her partner go to Vail for a month every summer. She has 3 children and 5 grandchildren. She often takes care of one of the grandchildren, Tom, who is about 1 year old. So these are just some things that are out there for us to take into consideration. Now, as we move through the process, I'm going to be giving you some insights, and with those insights, help us to be able to determine what it is we're going to ask or do next. So the first 2 insights are based off of questions that I typically ask my clients. So the first one to Jane was, what do you believe you are not able to do that you believe you should be able to do, right? So this is a question I ask many of my clients. And some of you might even switch it around and say, what do you believe you should be able to do that you believe you're not able to do right now, right? So either way, the idea is getting them to articulate why they are coming to see us. Sometimes as therapists and Pilates teachers, we assume that they're with us because of problems or pain or pathology. And more times than not, when I ask that question, I get very different answers. So I've learned not to put words in their mouth, or to ask things like, so where does it hurt? Or what's your problem, right? So this is one of my favorite questions. What do you believe you are not able to do that you believe you should be able to do right now, right? So she said, I want to be able to get up and down off the ground without pain in my knees and back. I want to continue hiking in Colorado in summer without being disabled the next couple days after hiking. And I want to be able to lift my grandson, who's approximately 30 pounds, Tom, without worrying about my back and knees giving out. So these are really key indicators of what Jane believes that she should be able to do. She believes that wholeheartedly she should be able to hike, she should be able to get up and down off the ground and do it without her knees and back hurting, and that she should be able to go to the mountains, and that she should be able to take care of her grandson. All of these things are very much human rights of movement, that we would call them in Polestar. The second question that I ask, and here's your second insight, and these are sort of like our games that we're going to be playing this afternoon. What do you believe prevents you from participating in these activities? So she already said she believed that she should be able to do these things and can't. This is her answer. My arthritis doesn't let me. Very important the way she said that. My arthritis doesn't let me. I have seen my doctor and he said on the x-rays, your joints look like a 90-year-old. Now, this is really important because very often we as Pilates teachers, doctors, physical therapists create the very image that feeds into the impairment or the disability. For example, you have a left leg length discrepancy. Your scoliosis is pretty bad. Wow, what do you do with your back when it's all curved over like that? Has anybody asked you about osteoporosis? A doctor looking at a disc, I always tell the story of Jack, who came to my office and had a true herniated disc pathology, and it was resolving. So he no longer had symptoms down his leg within about 3 weeks, and he got permission from his insurance company to get an MRI. So he went to get an MRI, and when he came back, I saw him dragging his right leg behind him in his left hand. This is back in the days where the films were actually printed out on plastic film, and he had these films in his left hand. And I said, what happened? And he says, well, I got my MRI, and the doctor said, this is the worst disc herniation he's seen in many years. It's a miracle that you can walk. And so you can see how our authority as the teacher, as the coach, as the doctor, as a therapist, actually has incredible impact on individuals. So I want you to think of these two insights that we've just received from Jane, right? So one is we know what she wants to do and what she's limited in doing, and we know what she believes is preventing her. So she's believing that arthritis is preventing her from participating, okay? So now we're going to go to the next slide, and this one is going to teach us how to use this new application we're going to play with today. So you're going to grab your phone, and in your phone, you're going to go to menti.com. We're going to take a second, and I don't want you to answer anything yet. I'm going to take you to the first slide, but I want you to go to menti.com, and then you're going to punch in the code number 245721, just like up on the screen. And that's going to allow you to answer the questions as we go through the different activities on this particular interactive case study. So if you go to www.menti.com and then enter in the number, gets us ready. And I'm going to take us to our first question. And that way you can sort of see what's going on here. But this is, you can see where to go to. I'm going to keep it up here all the time. So if you forget or you get bumped out or something happens, you can go back in. So www.menti.com, and the code is 245721. So before we assess Jane, just based on the subjective information to this point, what would you hypothesize Jane needs from us first and foremost? What, and we're talking as Pilates teachers today. So let's think of what we're thinking in our head based off of the first two insights and her history. What do you think, or how would you hypothesize what Jane needs before we even do an assessment? And when you're ready, you can go ahead and answer, and we're going to see that answer on the screen as you answer it. So we're going to take about a minute for you to get in there, and you can just get familiar with the app inside your phone. There we go. I see somebody starting to work with it. So just start answering your questions in there. And again, this is just a hypothesis. So there's no wrong or right. And the good news is it's autonomous. So anonymous, I mean, it's also autonomous, but it's anonymous. And just answer the questions the best you can. What are the top three? Here we go. And keep it going. We got like over 100 people online. So we want to see what we're really looking like, what we think. Yeah, we're 130 people on. So we've got, let's see, I'm trying to see if I can see how many have answered. Let's go another 15 seconds. And while you're doing that, let's go ahead and start talking about these. We can already see some interesting answers here, and they all have a place, don't they? It's not that any of them are wrong, or this is just our ability to sort of look and see what we actually think, right? So the first one that got the most interest was to create a positive movement experience without pain. And if you wrote this one, you know how, and you're dear to my heart from my research of dealing with pain, is sort of, if I create the experience, then I can explain and educate why she could have a diagnosis like arthritis and actually be completely functional and happy and have a good quality of life, right? Arthritis does not mean that you cannot participate in activities just because of an MRI diagnosis. It typically can be a false positive. So the question is can we give them the tools to be able to do that? And then education, you guys are right on the money. Education is a great way to be able to teach her that arthritis and the importance of focusing on function and not necessarily what the doctor said. And I find quite often that even with severe arthritic changes, that if movement is the best intervention, and so if we teach them good, safe movement interventions, these positive movement experiences, that we can make a big difference. And then third is identify what is needed to participate in the above activities. So that's exactly right. It's like saying, like, you chose these activities. So let's identify what it is that you want to be able to do, which we're going to do in the next section. Restoring strength to knees, core, and back. That will come naturally through a successful exercise program, and also through her being able to successfully participate in the activities that she chooses to participate in. And then 6 is just get her moving. Now, just get her moving maybe shouldn't be all the way down in 6. I like just get her moving. But I do think that I prefer the top one, which is to make sure that that movement is a positive movement experience. So these are all decent answers. And the 7th one is probably not our place to do this, but I do think that, educating her maybe more in the second option that came up might be a better place to be able to say, without disrespecting the physician and saying that he or she don't know what they're talking about, or they shouldn't be saying that. But it is a process of educating to saying that, there is research that shows that many people that have advanced arthritic changes by MRI have never had knee pain, back pain, or hip pain. So there is something unique that causes the pain. I'm not a doctor to know what that is necessarily, but I have seen many times people that participate in Pilates and learn and become aware of their bodies are able to participate more fully in life without having such severe pain. All right, very good. So that was our first example of using the Menti, and you guys did awesome. So very good. Let's go to the next question. So here, this is a short answer, right? So do keep them short. They're just going to show up. All 100 of your short answers are going to show up on the screen. But I want you to think and list now. Remember that third item that you picked was the activities. Identify the activities that Jane will need to be able to perform successfully to participate fully in her life. Remember, her participation was to go hiking, take care of her grandchild, be able to get up and down off the ground. So what activities would she need to be able to do in order to participate in the activities that she identifies as representing quality of her life? So go ahead and we'll take a minute and just type in a couple, if you write 2 or 3 answers in is fine of what you think. And it really does come down to that, but let's just see what people are thinking out there. So go ahead and start answering those questions on the next one. Well, sorry guys, let's get into the Q&A then. So you're going to write, let's do 1 in this case so that we're not too overwhelmed with 150 people on. So what would be your activities that you would say that Jane needs to be able to perform successfully to participate in her quality of life? So I see squat, walk, lift, down and up off the floor, bending, okay. So you're getting ahead of me, Ellen, because we're not ready to get on the equipment yet, but you're thinking on the right lines. You're getting close. Ankle flexion squats, good. Balance, okay. I think we're all barking up the right tree. That's great. Let's move into the next. Now, what I would say basically, if we go back to her questions, and you're right on the money, is she needs to be able to squat down and get on the ground, get up off the ground independently. She does need to bend over and pick up her grandson and pick him up and hold him without worrying about things. And she needs to be able to hike and walk. So we know that walking is also another biggie for her, to have endurance, and probably endurance upwards of a couple hours of walking if she's walking in Vel. And the other thing that I didn't see in here yet was just being able to go like up and down elevations. So if she's a hiker in Vail, Colorado, there's a lot of up and down. So she needs to be able to do things like go up and down stairs and those kind of things as well. So we want to think about that in our program. All right, let's go to the second insight here. So the second insight is going to be the physical presentation, right? How she shows up. So Jane presents as a slender, in-shaped woman, right? With pronounced kyphosis in her thoracic spine and a forward head posture. Her gait pattern has a very dominant heel strike. So that means when she's walking, she hits with her heel first, and you can hear it when she's walking on a floor that has sound. And in standing, she has a bit of a sway back and hangs on her hips. She stands with her feet turned out when resting, right? So if you think of, I often think of some of my dancers walk around like this a little bit, sort of hanging on those hips, feet turned out a little bit. So she doesn't really toe off in front, but she walks briskly and she hits that heel pretty tough. So thinking about that physical presentation, right? Keep that in mind as we sort of move through this. So we are going to look at the objective assessment, and this is going to help us now. Let's see if Menti's working any better here. So I got a lot of static posture, some dynamic, some flexibility. Let's define this. I see the biggest one. I think if we added them all up, I think dynamic would be first. So I would agree that I always like dynamic assessment, right? Looking at dynamic alignment. Static alignment, I sort of gave you already. So her static alignment was her posture turned out, increased kyphosis. I want to know what she can do with movement tests. So I want to know what she's able to participate in by looking at the actual movement, where a static test doesn't really tell me enough information, but a dynamic gives me a lot more information, even more than flexibility testing. So a lot of times as physical therapists, we would go test range of motion and flexibility. But to me, I don't even look at mobility until I see how they perform the functional task. Okay, so that's going to lead us to the next question, right? Let me see what's going on here. So we go to the next insight here. All right. So if we look at her dynamic alignment, this is what I found, okay? So I tested her half squat, I tested her goal post, looking at her shoulder movement, and also a walking assessment. So in the half squat, she was unable to perform a half squat with a vertical torso, right? Even after cueing. So one of the things I want you to remember when I talked about assessment skills, if I cue somebody and they're then able to do the movement correctly, was that a mobility or a load issue, or was it a body awareness issue? What do you think? You can answer in the Q&A. If I give somebody a verbal or tactile cue to do the task, and they're able to do it correctly after I give them the task, do you think that that is a mobility or load issue or a body awareness issue? And I'm seeing a lot of body awareness on there. You're exactly right. So If I make the correction, then I know I just need to teach them proper body awareness. If, however, after cueing, they're still unable to do the half squat or to do the correction, then I know that there's another issue at hand that I need to look at. And it could be mobility, it could be load, it could be something else, right? So she complained of stiffness in her hips and knees while doing the half squat. Upon further assessment, I put a 3-inch lift underneath her heels, like a half roll, and it significantly reduced the sense of stiffness in her knees and hips and improved her vertical orientation of thoracic spine. So I want you thinking about, why would raising the heels decrease the stress in her hips and knees and improve her vertical alignment of her torso, right? Sort of a cool outcome there. Now the other test, the other test that we looked at, sorry, let's get back. My PowerPoint got excited there. The other thing we looked at was the goalpost. Now she was unable to get her head against the wall even after cueing. So once again, we know that that was not an awareness problem. There was a structural limitation to her. Also not able to get her arms to 90-90. So that was due to immobility of thoracic spine and shoulders. Left shoulder was more limited than the right. We didn't attempt to do the V position with the arms, and that's what we saw on the goalpost. So you have to think about, where would the restrictions or the limitations be for Jane based on this goalpost test? And as I'm thinking of her function of being able to lift her grandchild and carry a grandchild or use her arms, lift them up, that this might be a problem if she can't get into a good vertical posture. And then the third test we did was looking at the walking assessment. And in her walking assessment, we saw that she sat that sway back posture and gait, strong heel strike, turn feet out to toe off. So what that means is she's rolling over the inside of her foot, her big toe, and she had bunions from that process. She never really got a springy toe off. So it was a very muscular pull from her hamstrings to be able to walk. There was no natural springiness to her walk. And if she's somebody that likes to hike, that could be a real problem. And the hips were forward of the torso. The pelvis remained in a little bit of a posterior tilt. What I mean by that is in relationship to the hips. So if the hips are pushed forward, it's sort of the same thing as the pelvis being tucked under. The range of motion in the actual hip joint is at an end of range in extension. So you could either have the pelvis tucked under to get that, or you could take the hip and the femur into extension to get the same limitation. And that's what she hung. So she used the ligaments of her hip to hold her body up rather than supporting herself. So her butt muscles, her butt musculature was pretty much not there, right? And again, I'm thinking she wants to hike and she goes to Vail to hike. I can see what she's doing is she's creating the imbalance on the posterior chain. So her hamstrings, somebody already mentioned tight calves and decreased ankle mobility, and you're exactly right, right? So these are some good things that we're picking up from here. All right, so let's go into the next slide. It works again. Well, Miracle, we'll go ahead and answer it. Is if you're back in your Menti, go ahead and answer this one. It looks like I have 4 people that answered it. So let's get some answers in here. If you can get into the Menti and use it and it's working, let's do it. And if you can't make that work, then you can go ahead and put your answers into the Q&A if you can't get back into Menti. Let's see where we're at, because I only see 4 people. Did more than 4 people respond to this one? So the question is the top 3 areas that you believe lack mobility, right? And this is the hypothesis that Jane is missing mobility. So I want to see what you guys are thinking. I'm seeing some good answers here. Good. I can see it. Let's go 30 more seconds. If you can get into Menti and make that happen, or give it to me on screen if you couldn't get into Menti. And give it to me in order, like what you think. So you're pretty much lining up with me on that. I like that. I like what I see here. Good, good, good. All right. Excellent. So this is very much in line with what I felt myself. I felt that the ankle dorsiflexion was a huge component to her ability to participate in the activities and what's probably causing her knee and hip pain and her back pain. So if we could get some more ankle dorsiflexion or modify for it, we could take a huge load off of those knees and off of her back. And I also thought that the thoracic spine extension was an obvious one because it's necessary for her to be able to squat as well, to be able to have that thoracic extension, to be able to use her arms and to be able to work with her grandchild in that position. So that's some cool ways that we can immediately look at, like, okay, I need to be thinking of getting ankle dorsiflexion, thoracic spine extension, and hip extension. Now she has some hip extension. What she's probably missing is hip internal rotation. Remember I said her feet are turned out? So I might put the hip internal rotation even above hip extension if I was looking at this for myself. And then obviously shoulder flexion. Now, one thing that we didn't talk about, but knee flexion often is not the problem. And one of the things that happens here is that the knees get beat up and they get painful because they're doing way too much work. There's too much load on the patella. There's too much load on the hamstrings from underneath, the calves, if they don't have the dorsiflexion. All of those things can be part of causing the knee flexion problem, right? And we know that if a lot of times, if you can slip something underneath the heel to compensate for the ankle, and they can squat and have decreased knee pain, then I'm not focusing on the knee, I'm focusing on the ankle. So a lot of you got that right in the money. I'm learning to look at all four things here, Melissa, so I can see the Q&A, chat, and also what's inside of Menti. And we're going to figure this Menti thing out because I think it's important for us to be able to play this game when we look at future case studies. All right, so let's go to the next level here. So now we want to create some goals and objectives, okay? And I am not sure what Menti is going to give us next, but let's see. So here, choose your top 3 choices. Looks like you guys have already done it, 73 of you. Very good. So again, the only thing I would correct in here, I think shoulder flexion will get better with thoracic extension. I think knee flexion will get better with ankle dorsiflexion. But with her, she hangs in hip extension. So the only thing I would change in your answer here is I would move number 4 up to number 3 and number 3 down to number 4. So we're really close to being on the same page. This is awesome, okay? Anybody have any questions on this up to this point? In the Q&A, anybody have any questions as to why we're sort of seeing this, this pattern manifest for Jane's case? Or how we're proceeding it? Does anybody have any questions on that? So we went from her subjective information that she gave us of what she wants to participate in and what she believes doesn't let her participate. We then made her hypothesis of what we think she might need. And then we chose our assessment based on what she wants to participate in. So we knew that she needed to get on the ground and up. And so we had to squat. We knew she had to lift a baby, bend over. So we looked at a couple tests, and then hiking, looking at her walking. We came up with some limitations. We tested to see if she could do it through awareness. And if she couldn't, then we were going to look at mobility. So this is where we are now, is that we've chosen that we want to focus our primary objective to increasing ankle dorsiflexion and thoracic spine extension. And then I would say more hip internal rotation, because she's going to need that to have that springiness again. And also we're going to be looking at some functional gait patterns. Let's see, I got some comments coming in now. So let's see what you guys are saying. Kyphotic posture, limitations of mobility and thoracic spine, but this may be habitual patterning. And you're absolutely right. we know that through doing things like even getting on the spine corrector every day or the OOV every day, being conscious, standing up against the wall every day, that people older than 60 are able to make significant changes in their spine vertical posture. And so this is something that we deal with and can help people a lot as Pilates teachers. So very exciting, right? Adrienne Bentley talks about tight calf muscles and ankle mobility. Sometimes that ankle tightness could be related to what Eric Franklin talks about as bone rhythms. So if we're not teaching the right bone rhythms, we might lose that range of motion. Sometimes there's just a lack of glide inside the talus, and they truly have a mobility or structural limitation, might need some physical therapy. Sometimes it could just be some tight heel cords that need to be stretched. So they need to be doing the Hercules stretch or Achilles stretch frequently to be able to loosen that calf muscle up. Sarah said, continue saying limitation of mobility in thoracic spine. Oh, you said that, I said that already. Tight hamstrings. All right. So let's move on to the next thing here. I see some other things coming up on the chat. Please elaborate on the hanging and work internal rotation. Let me demonstrate it for you. So what Jane was doing was she's in this position here, kyphotic upper back, hanging on the hips. So if you hang on the Y ligaments, it's as if you are in hip extension. But the way that she does it is she's turned out. So she has about a 45-degree external rotation that is her resting posture, which tells me that she does not have ankle dorsiflexion. We know that. And she might not have internal rotation to allow her to propel herself. One of the things that we'll need to teach her is also maybe how to walk again, right? So to get a midfoot strike and to try to work on that axial elongation and get her out of that sway back posture hanging on those ligaments. She has found a way to support herself, right, by hanging on the inert structures in her body, like the anterior Y ligaments of the hip, hanging on her low back, hanging on her thoracic spine. And now we're going to be saying, let's get some mobility and get you to have control over that mobility in a better, more functional dynamic alignment. Dagmara said in sway back, you need to work on hip extension and build a butt because you hang on your hips. Yeah, it's an interesting thing. What you have to do is get the pelvis to come up over the hips and get the body weight to go forward. And then there's some very unique things that we have to do to be able to shift that energy into the posterior chain. One of the problems we have in our society now is sedentarism. And sedentary often weakens and makes the posterior chain very flaccid, very weak. So a lot of times people in this kind of posture will hang on the ligaments and have no connectivity, no elasticity in the posterior chain. But rather what they do is they hang on the ligaments, and you'll see the hamstrings will become tight, the ankle dorsiflexion becomes limited, and the buttocks becomes nothing, like it just almost disappears. And the same with the rotators in the hip. So they become very weak. And that is a very good formula for knee pathology. So one of my friends, Dr. Chris Powers out of USC, has done a lot of work looking at knee pathology as it pertains to poor hip extensors, abductors, and external rotators. And so that's exactly where Jane is. So that's one of the things we're going to want to focus on, is being able to get the mobility in her thoracic, mobility in her ankles, get the mobility in her hip, internal and extension, and then get her to start now loading those tissues so the muscles can reactivate with normal alignment that she has not been able to get into. So a very good discussion, very good point that you bring out. Let's see, I saw a couple other good points come before we wrap this up with the final part of this, question 6. Let's see, Georgetta Rubo said, could we bring hips back in alignment by working on adductors? And that's what we're working on, right? It's going to be adductors, external rotators, and extensors. But here's my problem with that suggestion. And I'm going to be real frank with you, because this is something that is very common. We don't strengthen it by doing isolated muscle contractions. So what we have to try to do then is create proper functional movement that forces those hips to start waking up. I'll give you a good example. After I had my hip replacement a year and a half ago, I was seeing my physical therapist. He's also a Feldenkrais fellow here in North Carolina, a good friend of mine. He was on the show last week, actually, Brian. And Brian had me doing some Tai Chi activity. Now, you would think the Tai Chi activity might not activate those muscles as much as you would think, but he had me doing a half squat and then rotating as I stood on one leg, keeping the knee in its parallel position. And it was that slow, controlled opening. Matter of fact, I'll even show it to you in a second. That really, at first, I couldn't even do it. I had no idea. I had not used my right hip flexors, hip abductors and rotators for years because of the arthritis in it. There wasn't the motion. So I was relying on the bony end of range of motion to hold me up in a squat, not on the elastic tissues of the myofascial tissue. And so what he was doing was introducing it back into me. And very quickly, those muscles came back to life. And for the first time, I felt my glutes, abductors, and rotators in my right hip after many years of not feeling it. And it perked right back up and became very elastic again. And actually has served me quite well since the hip surgery. So I've been very happy with it. So how do we create those optimal load situations, right? We got to make sure we have the mobility. Like if I didn't address her ankles and I kept addressing her to do half squats with spring assistance, then I'm not going to be really getting into the right place. So I'd have to lift the heels up a little bit in the beginning and teach her to start getting the strength in the right muscles without pain. That positive movement experience that the majority of you picked in the beginning was right on the money, right? So good job. Let's see, a couple others. So Jonathan mentioned that he asks his clients to walk with their feet parallel. By walking this way, it will activate inactive muscles. And you're right. When we create the desired load and the desired pattern of alignment, dynamic alignment, then often the soft tissue and the neuromuscular system has to adapt to what we're asking to do. And so these are the kind of things that, when we're doing footwork, we can create that organization to be able to do that, to be able to create the right load. When we're doing the chair and standing, or we're doing squats, or we're doing lunges on the chair, we can create the proper alignment to make sure that they're not losing the alignment, compensating with other muscle groups that would continue to perpetuate the same problem. So if they're doing a lunge on the chair, right, and they turn their leg out, up there with their foot out, right? Now you're going to see that they're going to cheat. They're going to use different muscles to be able to get up than the ones that they need for walking or climbing mountains or hiking, as Jane is interested in doing. You guys are awesome. This is some good stuff. Let's see if I got anything else on this other side before we go there. Marie Student, hello Marie. She's our licensee in New Zealand. So glad you're with us. She said, how about bringing the rib cage forward over the pelvis, i.e. collarbones over pubic bone? Fantastic alignment idea, right? If we can create the image inside of our clients of where their body could be in position. Like most of the time, these people have no idea. They think they're standing up straight, right? So we can move other parts of the body through space. So as Marie suggests, imagine that whole rib cage, right? Translating. It's not lifting the rib cage up, going back into more extension. It's just translating the rib cage so it's over the pelvis. I often use an image of 3 tubes. So I think of one tube that's in the most center, which surrounds the spine, and then another tube that would be about the width of our head down to the inside of the pelvis that surrounds that spine tube. And then there's a thoracic outer pelvis tube that surrounds the other 2 tubes that goes down. So if there's parts of that tube that we have kinked or collapsed, we've lost the dynamic alignment. And so now we don't have flow, we don't have reciprocal forces, we don't have the ability to absorb ground reaction forces, and we start perpetuating a lot of the problems that we see in our day. So great point, able to sort of align those tubes in space. Let's see, Brigitte said, hi Brent, during toe off when walking, when the hip is in extension, it is also in internal rotation. Yes, So one of the things you think of when we heel strike in supination. And then as we come into mid stance, we're actually internally rotating going into pronation. That's our deceleration, right? So as the knee bends, the femur spirals in, tibia spirals out, foot spirals in, right? And then as we get closer and out of mid stance, right? We talked about gait a little bit a while ago, but we get closer that out, the ankle becomes rigid because of the width in the front of the ankle. The foot starts to go into supination, and then we go into a little bit of external rotation on the toe off in the swing phase of gait. And it's just us, the more we understand, it really does help us facilitate better what we can get very quickly out of our clients. I want to demonstrate that Tai Chi move for you before I move on to the last part in the last 10 minutes of the webinar today. So maybe you could do it with me. Maybe you stand up. It's very simple, and we'll all do it together, okay? So let me just get my camera so you can see. So I'm going to put the camera down on my legs so you can see what we're doing. But I go into a half squat position. And I open up to the side and back. Open up and back. So the key is my right knee stays over my right foot. What I'm doing is rotating my pelvis around the femoral head with no weight really on my left leg. And I set that down. And then I bring it back home. So I'm having to use my external rotators and my glutes, maintain my body upright in this activity, right? So this has been a very good activity for me to be able to re-educate my hip extensors, my rotators, and abductors. Were you guys able to see that? Yes, no? Okay, all right. So let's move on. Let's finish this case up. You guys have done great so far. Your questions are right on the money. So here we are with question 6. And let's see if this one works, if it pops up for you. But what modifications will you possibly need to make to create a positive movement experience for Jane with what we know already? And it could be any ideas. Let's see if Menti is working. Yeah, somebody wrote, it's almost like the standing clam. It's exactly like the standing clam, but that load in standing makes all the difference in the world. So it's pretty cool. Let's see, are we able to? Menti's working. We should start seeing some of your answers pop up here. You just write them in if it's working. Yep, I see that it's working for some of you. Let's see what your answers look like. So this would be examples of modifications. So what kind of modifications would you make or need to make for her based on her assessment? There we go. All right. Good. So we're seeing some answers come in from 6 people. Let's see if we can get 70 people putting some answers in there. Giorgio, I want to see your answers. If you can't get it in there, you're welcome to put it into your Q&A. I'll be looking at both. There we go. Now we're seeing them. Let's get something good. We will figure this out because I think this is a great way for us to see what everybody's thinking, and we'll tweak it and we'll get it better. And we want to hear from you if this is something that you like in the interactiveness where we can have, 200 people participating and being able to see how they're doing with their problem solving. So there we go. Look at that. Another 22 came in. All right. So let's read some of these. Standing with the heels raised, propped heel squat. So we're seeing a lot of, props maybe underneath the hip. Some of you have your exercises in here already, which I'm going to save that one for the very last, right? But it looks like the majority of the answers consistent in here are raising the heels. There we go, 31 more on. The other is to decrease the effect of gravity. and some are looking at some modifications to the thoracic spine, starting with simple movements first and then progressing. Prop HNS, somebody help me out. What's HNS? Write it out. Standing clam, lunges. Oh, I'm loving that. It's great that we can see all these things. Head, neck, shoulders. Thank you. Yes, good job. You're doing your PT acronyms. All right, very good. So you can see that you're all sort of in that same area. You're seeing what we need to do, and you're seeing the most common responses are the ones that are horizontal, yeah? So very cool, nice work. All right, let's go to the program design part of this. And let's just test our knowledge. We're just about out of time here, but this is the last Mentimeter. And this one is just putting up like an exercise you feel this person would have to do in whatever you're doing as your whole body workout. Pick your favorite exercise that you feel is a must for Jane. And that's how we'll finish up our case study today. And then if I was you, I would take a picture of it and think of like, okay, there's some great ideas coming from a lot of people in our community here. So let's see. So you're going to share your favorite exercise. Let's get it going. We got 11 people in. Let's see if we can get over 70 people in on this one. Let's see if we can get up to 70. We got 140 people that are on live right now. We have over 500 people that are registered for it, so they'll get to see what your thoughts are. I see some coming up on the chat. We got some more coming in. Sarah put scooter with thoracic extension. Love it. Footwork on the reformer. I see a lot of footwork. I want to get a lot of squat activity too, right? Squats with modifications. You guys all mentioned you would put some kind of heel lift for a full weighted squat. Let's see what we got. We're going to get another big change here. There we go. Starting to see some more. So what happens is it recognizes when you put footwork in, so it's identified footwork as the most common one. I'd like to see squat a little bit bigger as well. So let's see if squat comes back a little bit more, because that's really the modified squat off the end of the trapeze table was my must. So a heel raise on top of a half roll, doing assisted squats with springs from above with the dowel on the trapeze table. That was my go-to. All right. Well, you guys did great. I see 50 people responded. Let's give it one more minute and then we'll move into questions and answers on the process, right? On what we just went through, and see if this was helpful to you. What would be things you'd like to know? What else could help you with that? Very good. All right. So I'm going to close this slide down. We're going to go into Q&A time. And thank you for participating on the Menti and testing that out. We'll continue to play with it and get it so that we have better and better questions and visibility on that. I think it's going to be a really fun one for us. All right. So what I would like to know now from you is letting me know what parts of this you liked. If you have questions about the actual process of the case study that we did today, and if you felt that you enjoyed participating in a virtual sense, even though we can't be together doing this case study, if it was helpful to you, if you felt like you could take something from today and be able to apply it to your clients in the future through this problem-solving methodology. And Susan Hart mentions that the footwork is a squat. It is a horizontal squat, and that's why it's such a beautiful exercise. It's closed chain. We modify the actual load on it, so that's what makes it so awesome. And we can do that, but eventually we need to get them up into the vertical orientation of gravity. You can't get the springs hard enough to really give a good vertical appearance on it. So let's see what we got going. People liked it, loved it, interesting to do Menti. We'll continue to make that better. Found it very helpful today. Aline loved it. Lisa, very helpful. Thank you guys. Looking over in the chats. Sinead said, would love to have more webinars on what does it mean when you see X. I think this is a good way to do it, because if we keep bringing in different case studies, we will see a lot of X's. We'll see a lot of different signs and symptoms. You can certainly submit to me one that if you have a case that you would like to have presented in one of these interactive case studies, we're going to be having more of them. You could maybe submit that to me or to Melissa, and we would consider making that the interactive case. So that could be a fun thing that we could do as well. Let's see, from Donna Bear, she said, as a PT, would have liked lots more time spent getting your expertise in specific Pilates progressions. That is another day, and we can certainly do that. Not a problem. All right, so I see a lot of positive feedback there. See if anybody else had any questions. So we will continue to refine Menti, and I think as we figure out how to use it, I'm going to try to get it so that I can actually end up with an actual exercise program that we could make with the group dynamically. So that would be fun to do as well. A lot of times what I find is that the collective sees things much better than any of the individuals. So we learn by hearing each other's ideas. We learn by hearing other people's thought processes, and it's much better than me being on my own. So I appreciate your feedback today and your ideas. I saw a lot of cool stuff. And Adrian wants to do some Tai Chi. So maybe what we'll do is we'll bring Brian on to, he's a Tai Chi instructor and Feldenkrais practitioner. Maybe we'll bring Brian on to do some Tai Chi for us or something like that in the near future. While we're just finishing up and wrapping up here, next week, I'm going to have Victor from the Connector with Balanced Body. He provides the education on how to use the connector on the reformers, if you haven't seen that yet. I've been talking to him a lot lately, asking him how he's been coping more on a personal basis and a business basis in education, and how he is transferring his education into the virtual to be able to deal with COVID and also the lack of ability to travel. So for many of us, you know, we travel all over the world doing education, and that of course has been stopped. So how do we pivot and provide education to people around us by the virtual? So next week's going to be very fun with Victor. And then the following week, I believe, is Thanksgiving. So we're going to be taking a break on Thanksgiving. We want you to be with your family, friends, or just having a nice, quiet, healthy time if you're on your own, and meditating, expressing gratitude for the many things that we do have. And then on the 3rd, we have great programming. I'm inviting Joseph Quinn. Many of you know Joseph from Pilates Metrics in the Pilates world. And we're going to be talking about the whole idea of documentation of our visits and how we measure outcomes and how we design programs and see if our programs are actually working for us. And so that's going to be great. And then following that, I'm going to do another interactive case study. So we'll have Victor, Thanksgiving, Joseph Quinn, and then we'll do another interactive case study. So we hope to see you in all 3 of the upcoming webinars. Thank you for your participation today. Good to see so much writing going on. My goodness, we haven't had this much participation ever, so this is the best one. And again, if you have any suggestions for us, like I know that we'll maybe try to get a better, maybe on the Pilates end of it for some of you, looking at how we can discuss how we design. And then also we can look at some of the more nitty gritty of going back. And again, you can go back to that, the one webinar that we talked about assessment, where we went from how we use the Polestar assessment tool, right? So we'll be doing more of that, but that's how I went through it today. So I looked at, could they do the actual task that I was asking her to do? And then I assessed it. And if they didn't correct with verbal or tactile cueing, I then went to mobility. If she had the mobility but still couldn't do the activity, then I would go to control, the principles in Polestar. And then I would look at her ability to have enough strength or endurance or neuromuscular control of that movement. And that would tell me where I need to put my emphasis. So today we spent it on mobility, and we ended up with mobility of the ankle and the thoracic spine. So you guys are right on the money. Thank you so much. Please be safe, everybody. Just because the election over doesn't mean we need to stop wearing masks. So keep wearing masks, keep your distance, stay safe, and good luck with all of your training. We sure appreciate you coming on and taking time out of your day to be with us in the Pilates Hour. And we will see you next Thursday, same time, same place at the Polestar Pilates Hour.